Bismillah ar-Rahman ar-Rahim. Again to the second part of this lecture. The idiopathic interstitial pneumonias comprise a heterogeneous group of disorders, at least 7 to 8 subtypes. They have certain histological types, clinical features, and radiological appearance. All of them represent fundamental responses of the lung to the injury and don't represent disease per se. That is to mean that we have different patterns of response of the lung having the name of the subtypes of these idiopathic interstitial pneumonias, not specific disease per se, but it is a pattern of response or histopathological pattern. As I've told you, when we say idiopathic, it means that we don't know what the cause. Okay? These diseases have specific patterns of morphological findings on high-resolution CT and histology. Before we call these findings idiopathic or cryptogenic, we should realize that these patterns are common findings in collagenic vascular disease, scleroderma, rheumatoid arthritis, and drug-induced lung disease. For example, patients with rheumatoid arthritis can present by nonspecific interstitial pneumonia, usual interstitial pneumonia, and so on. So if the patient have a cause, we will not call them idiopathic. But if the patient has no cause, we will use the word idiopathic interstitial. This table, as you see, summarize the clinical differential diagnosis, the high-resolution findings, distribution, key findings, and the clinical of the most common 7 types. Okay, these are the most common 7 types or subtypes of idiopathic pneumonia. Let us run, and the most important one, usual interstitial pneumonitis, or as we use in everyday practice, the word UIP. It is a histological diagnosis. If UIP pattern has a known cause, has no known cause, so we will call it idiopathic, and this is what is known as idiopathic pulmonary fibrosis, which accounts for more than 60% of the causes of UIP. In the presence of surgical biopsy showing UIP pattern, the diagnosis of interstitial pulmonary fibrosis requires to exclude other known causes of UIP, such as drug toxicity, environmental exposures, collagen vascular disease, and so on. A long list of drugs also have been incriminated in causing UIP pattern. It is very important for the clinician, the role of radiologists in telling the differentiation between nonspecific interstitial pneumonia and UIP, because there is very variable implications on the patient prognosis and on the treatment therapy. UIP has a bad reputation because it is more progressive, and more than 50% of patients have short survival time. But recently there is a new drug that stops fibrosis in UIP or frozen UIP. And this is important now to tell the clinician, is it UIP pattern or not? Because UIP now can have this treatment, which is very expensive, but it seems it has a promise in the future treatment. What are the high-resolution findings? And this is very important for us. Presence of honeycombing. You remember honeycombing? Presence of irregular septal thickening, architectural distortion and traction bronchiectasis, These represent sure signs of lung fibrosis. You remember that? These changes are predominantly seen in the basal and subpleural region, and this is very important. Sometimes we can see lymphadenopathy, presence of ground glass opacity as an isolated finding may be seen due to fibrosis or represent acute exacerbation on top of UIP. Let us see. This is typical. In plain X-ray, you will see that there is a reticular pattern involving the basal and peripheral subpleural areas of the lung, and you can see shaggy border of the diaphragm and the heart. Okay, shaggy border, and you can see cystic spaces which match with honeycombing. In CT, peripheral subpleural fibrotic changes with honeycombing, traction bronchiectasis, and distortion of the lung parenchyma. Again, you can see this in early stage, more advanced stage, honeycombing. Sometimes there is enlargement of the cysts of honeycombing. You can see areas of ground glass opacities as well as intralobular septal thickening, which is a sign of lung fibrosis. So these are the very characteristic features of UI pattern. The second disease is nonspecific interstitial pneumonia, which is called in everyday practice NSIP. Okay, NSIP. Some authors consider NSIP as a specific entity, while others consider it the waste basket diagnosis when we don't diagnose UIP or DIP or OP. So we can call it NSIP from the name, non-specific, but actually it is more complicated than this. NSIP is not a diagnosis by itself, as I have told, it is a pattern of lung damage. The role of radiologist to tell the clinician that it is UIP or not UIP pattern. And I will show to you at the end of this part of the presentation how we can report these cases and to tell, is it UIP, definite, possible UIP pattern, or not consistent with UIP pattern. This is our rule. NSIP is by far has better prognosis than UIP, and it is the most common interstitial lung disease in patients with connective tissue. What are the high resolution pattern? The predominant finding is ground glass opacity or patchy consolidation, irregular reticulations, with evidence of fibrosis manifested as traction bronchiectasis at the areas of ground glass opacities, absence or minimal honeycombing. And here I would like to say that don't mention NSIP if you see honeycombing. Honeycombing is more or less with UIP pattern. The location is concentric subpleural and basal predominance, with some authors reporting the presence of thin rim of subpleural sparing. NSIP should be strongly considered if high-resolution CT shows concentric subpleural and basal ground glass opacities without honeycombing. This is what we want to say. You see honeycombing here, you see ground glass opacity here with traction bronchiectasis. Okay, you can see some reticular pattern with ground glass opacities, and as you see, there is some sort of subpleural thin rim of sparing normal lung. Okay, but in all these cases, we don't see honeycombing. Again, rim of ground glass, concentric, subpleural, with some sparing of the thin rim subpleural area. NSIP is of two types. NSIP is actually of two types. One is called cellular and the other is called fibrosing NSIP. Cellular, if we see ground glass opacities without signs of definite fibrosis such as traction bronchiectasis, distortion of the fissures, distortion of the lung parenchyma. Fibrosing type, if we see ground glass opacities associated with traction bronchiectasis, bronchiolectasis, and other signs of fibrosis except for honeycombing. These three patients are suffering from connective tissue disease, and all of them presented by NSIP. As you see, these are ground glass opacities having peripheral, basal pattern. Again, this is ground glass opacity. Ground glass opacity with some sort of traction. Is cryptogenic organizing pneumonia. Previously, it was described as bronchiolitis obliterans with organizing pneumonia, POOP, but the new name now is organizing pneumonia or cryptogenic organizing pneumonia or COOP. It is an inflammatory process in which healing process is characterized by organization of the exudate rather than resolution, meaning that there is unresolved pneumonia. Organizing pneumonia is mostly idiopathic. So if we don't have a cause, we can call it cryptogenic organizing pneumonia. But it is also seen in patients with pulmonary infection, drug reaction, collagen vascular disease, vaginal granulomatosis, toxic fumes, and once we have a known cause, we cannot call it cryptogenic. We will tell it as organizing pneumonia secondary to connective tissue disease. Okay? Organizing pneumonia presents with a several-month history of non-productive cough, low-grade fever, malaise, and dyspnea, with a good response to corticosteroids and good prognosis. Again, this is the second great mimicker in this lecture because it can present with a different pattern of high-resolution signs and presentations. What are the findings? It could present as patchy consolidation or ground glass opacities, often in subpleural or peribronchial distribution. It can present as a small ill-defined nodules, peribronchial or centrilobular, large nodules or masses, focal or lobar consolidations, atoll sign, okay? And this was the first to be described as a specific for cryptogenic organizing pneumonia, but actually it is not that specific. The other thing that the consolidations may be migratory. On follow-up, you see that the consolidations are moving from areas to areas. Lesions may show pleural tags or spiculae and give the impression of volume loss and slight retraction of the surrounding parenchyma, simulating bronchogenic carcinoma. Also, we can see bronchial wall thickening and dilatation, which is seen in most patients and usually restricted areas of consolidation or ground glass opacities. Additional findings include pleural thickening, small pleural effusions, parenchymal bands, the pattern of growth, the pattern of linear opacities called perilobular pattern of reticular thickening. As you see in this case, there is bronchial wall thickening, peribronchial consolidations, okay, some nodules. Here you find areas of consolidation with air bronchogram, areas of consolidation peripheral, as we have told you, okay, before. You can see it simulating the chronic eosinophilic. This is the specific atoll sign, okay, but take care. This atoll sign is not only specific for COOP, but most commonly it is seen in cases of cryptogenic pneumonia. The disease number is category respiratory bronchiolitis, respiratory bronchiolitis associated interstitial lung disease, and desquamative interstitial pneumonia. These three patterns represent different degrees or spectrum of severity of a small airway and parenchymal reaction to cigarette smoking. Okay, respiratory bronchiolitis is the mildest. Desquamative interstitial pneumonitis is the severest. 90% of these patients are smokers, 10% idiopathic, and can or may be seen in cases of inhalations, drugs, and hostocytosis, but take care that smoking is the major cause of this category. All smokers have various degrees of respiratory bronchiolitis, but it is usually asymptomatic. 5 to 10% of smokers have a clinically significant lung disease in association with respiratory bronchiolitis, presenting with symptoms, lung function test, and auscultatory findings on clinical examination. The term respiratory bronchiolitis interstitial lung disease was proposed to describe centrilobular lung disease in patients, and the term diffuse or desquamative interstitial pneumonitis was used to describe a more diffuse disorder. As I have told you, it is a spectrum from the mild to the severest in smokers. Radiologically, these diseases cannot be clearly separated because of the OT findings. Let us see. The most severe, desquamative interstitial pneumonia. Ground glass opacities with subpleural and lower lobe predominance in 70% of cases, and in 30% diffuse ground glass opacities or mosaic attenuation. You can see septal thickening, no honeycombing, and you can see also centrilobular emphysematous and patchy air trapping areas on expiratory films, in addition to lung cysts. So, desquamative interstitial pneumonia, lower lobe predominance, or so diffuse, and the key finding is ground glass opacities with centrilobular emphysema, air trapping, as well as area cysts. While in the milder form, we can see centrilobular nodules of ground glass opacities with upper lobar predominance. Or we can see patchy ground glass opacities, bronchial wall thickening, centrilobular emphysema, and air trapping on films. This is an example of respiratory bronchiolitis interstitial lung disease. As you see, we see ground glass opacifications, thickening of the interlobular septi, and in addition to areas of centrilobular emphysema. This slide is repeated from the previous lecture. As I've told you, ground glass opacity is not that specific, and the clinical is very important in this situation. If the patient is a smoker, you should first think of respiratory bronchiolitis interstitial lung disease. If immunocompromised, you should think of pneumocystis carinii pneumonia. If the patient is coughing blood, you should think of pulmonary hemorrhage. If the patient is a bird breeder or a farmer, you should think first of hypersensitivity pneumonitis, especially if they are centrilobular ground glass opacities. Okay? The disease number 4. Acute interstitial pneumonia, AIP, previously called hemorrhage pneumonitis. It is a rare idiopathic lung disease characterized by diffuse alveolar damage, okay, which is called DAD, with subsequent fibrosis. It has a fatal outcome in many cases. The histological pattern as well as the high resolution CT findings are similar to ARDS, but as I've told you, clinically ARDS has risk factors, either pulmonary or extrapulmonary. This one is idiopathic. All of a sudden, it occurs as acute respiratory distress pattern. The high-resolution characteristic features include diffuse or patchy consolidation, crazy paving appearance, ground glass opacities. These abnormalities develops in several days, and this rapid progression of the disease combined with the imaging findings are very suggestive of the diagnosis of acute interstitial. This is how it appears. It looks like ground glass opacities like this, in addition to the crazy paving pattern, or it can be white lung with consolidation simulating pulmonary edema, extensive pulmonary edema, and ARDS. Disease now, lymphocytic interstitial pneumonitis, LIP. LIP is uncommon. This is one of the rare. It is seen in two categories of patients: autoimmune disease such as Sjogren syndrome and patient with AIDS. Symptoms are non-specific. The high resolution findings are also non-specific, ground glass opacities, and often lesions. What we can see: patches of ground glass, nematoceles, air of cystic changes, no honeycombing, no other signs of fibrosis. If the patient is Sjogren syndrome, okay, this is LIP. If the patient is AIDS patient, you can think of two things which have the same pattern, ground glass and cysts: pneumocystis carinii pneumonia or LIP. In this situation, lab work and alveolar bronchoalveolar lavage may help in the differentiation between LIP and pneumocystis carinii pneumonia, and even empirical treatment trying to see what is the underlying. This is called LIP, and as you see, the patient must be Sjogren syndrome patient. Our role in reporting these types of idiopathic pneumonias or cryptogenic pneumonias is to differentiate one of these three categories. Number one, UIP pattern or definite UIP pattern. Number two, possible UIP pattern, or the pattern is inconsistent with UIP. UIP pattern, we should have all these four criteria. The distribution is subpleural basal predominance. The main pattern of interstitial disease is reticular. Mainly, honeycombing must be there with or without traction bronchiectasis, and absence of this lists. Okay? Possible UIP pattern, and this is the most important one not to be missed. It simulates the mild degrees of NSIP. We see subpleural and basal predominance, reticular abnormalities rather than ground glass opacities, and absence of these findings. What are these findings that when we see it, we tell the doctor, referring doctor, that it is inconsistent with UIP? If we have upper and middle lobe or middle lung zone predominance, if the distribution is very bronchovascular, if there is extensive ground glass opacities, diffuse micronodules, discrete cysts, mosaic attenuation with air trapping, peribronchial or lobar consolidation. As you see, each one of this point to one of the diseases that we have described before. This is the possible UIP pattern, and this is very important, as I've told you. You can see just reticulations at the subpleural region in the lung basis. You don't see honeycombing, and you don't see extensive ground glass opacities. Once I see this pattern, I report this is a possible UIP pattern. It could be early UIP or early NSIP. Here and the clinician should proceed to biopsy, because he wants to know, is it UIP to start the antifibrotic treatment, the new antifibrotic treatment, or it is NSIP to start corticosteroids, and this patient is in early stage, will benefit from corticosteroids. If the patient is definite UIP, there is honeycombing, basal, and subpleural distribution, all the four items, So the doctor will start immediately the antifibrotic treatment without biopsy. As you know, lung biopsy is serious and it has a lot of complications. If the patient is inconsistent with UIP, he will find other treatments such as corticosteroids, stopping the offending agent, treating the connective tissue disease underneath the pathology, corticosteroids, immunomodulation, and so on, not the antifibrotic treatment IP. Herein, I want also to add there are new entities under the idiopathic pneumonias rather than these 7 diseases. One of it is the combined pulmonary fibrosis. This means that we have emphysema, either paraseptal or centrilobular, plus interstitial lung fibrosis or interstitial lung pneumonias of any type, okay, combined. Usually we see this entity in, this is an example. The upper lobe shows centrilobular emphysema, while the lower lobes show honeycombing due to UIP. So this is a combined emphysema and pulmonary fibrosis of UIP. Again, the lower lobes show honeycombing, the upper lobes shows paraseptal emphysema. Emphysema composed of fibrosis involving the pleura and the subpleural lung parenchyma, usually at the lung apices, and typically progress to involve the entire lung. Okay, so location-wise, it is in the apices of the lung. It starts in the pleura and infiltrates upper lobes. It is considered as a rare disorder. However, it is very likely to be both recognized and misdiagnosed, as I've told you. It is seen in adults in the 3rd and 4th decades. There is no gender predominance. It occurs most commonly in patients with absence of smoking habits. The etiology of the disease is unclear. The most common reported symptoms and signs are dyspnea, non-productive cough, weight loss, and pneumothorax. One of the very important clinical manifestation of this entity is that fibrosis results in flattening of the upper chest, which is called platythorax, due to retraction in the anteroposterior. In CT, we see pleural thickening associated with subpleural fibrotic changes, concentrated in the upper lobes with involvement of the lower lobes being less marked or absent. The associated features include upper lobe volume loss, platythorax in clinical, architectural distortion, and traction bronchiectasis. In addition, we can see localized pneumothorax to, let us see, pleural thickening, pleural fibrosis with fibrotic bands that proceed into the apices, in addition to presence of pneumothorax. If in clinical situation this is correct, we can diagnose pleuroparenchymatous fibrosis. Again, fibrotic bands in the lung apices with pleural thickening. Actually, in old days, we usually call this upper lobar scarring secondary to old TP. And put in mind also that this, so the patient should be should have the corresponding typical clinical presentation, platythorax, and on follow-up, this procedure is progressive. If it is stationary, it is not pleuroparenchymatous fibroelastosis. It has a progressive course to diagnose it. Pleural thickening, fibrotic changes, and it can proceed later on to the lower lobes. It starts in the upper lobe with in addition. Now, the disease number, drug-induced lung disease. There is a long list of drug-induced lung disease. We have discussed them before. If the patient is known to have a certain drug, okay, such as chemotherapy and other therapies, you can think of reaction of the lung to these drugs, called drug-induced lung disease having any pattern. It can be COOP, eosinophilic pneumonia, ARDS, hypersensitivity pneumonitis. Okay, so drug history can explain a cause for interstitial lung disease. Now, two rare but having a specific or pathognomonic or spot diagnosis pattern of high resolution CT. The first one is lymphangiomyomatosis, okay, or lymphangiomyomatosis. This is a rare disease. It should be seen in premenopausal women because it is estrogen dependent, or in patient with tuberous sclerosis. It is called LAM, okay, lymphangiomyomatosis, LAM, okay. Usually we see it as multiple lung cysts that involve the whole lung, not sparing any areas. The clinical findings, dyspnea, rupture of these cysts into the pleural space can result in pneumothorax, spontaneous pneumothorax, or chylous pleural effusion. And as I've told you, if the patient has tuberous sclerosis, he can be male or female, but if no tuberous sclerosis, it is seen in premenopausal women because dependent. How we can see it? Numerous thin-walled cysts surrounded by normal parenchyma. Cysts range from 2 mm to 5 centimeters. Cysts are distributed all through the lobes. Okay, wall thickness of these cysts is very thin, about perceptible up to 4 mm. The mediastinal or hilar adenopathies or pleural effusion seen in 40%, but is seen in 40%. As you see, the lung is normal, but it is studded with multiple thin-walled cysts. If the clinical situation is matching, she is a premenopausal woman or a tuberous sclerosis patient, we can diagnose LAM. And as you see, one of these cysts may rupture, resulting in pneumothorax or chylous effusion. The second disease is Langerhans cell histocytosis. This is called pulmonary histocytosis X or eosinophilic granuloma, similar to those seen in childhood. Langerhans cell histocytosis is probably an allergic reaction to cigarette smoking, since more than 80% of patients are active smokers. So Langerhans cell histocytosis has a strong correlation with smoking, such as the diseases, the smoking-related diseases we have described: respiratory, bromcolitis, interstitial lung disease, and squamative interstitial pneumonitis. In the early nodular stage, it is characterized by centrilobular granulomatous reaction by Langerhans histocytes. Then they cavitate, forming bizarre-shaped cysts with process. In the early stage, we see that the lung are studded by centrilobular nodules, usually in the upper lobes, sparing the costophrenic angles and the basis of the. Later on, these nodules enlarge, cavitate, forming cysts of relatively bizarre shape, thick wall, like this. Okay? So it starts as centrilobular nodule, then these cysts enlarge and have bizarre shape and mecoalese, and then become larger in size. As we have told you, upper and middle lobe predominance is important. Recurrent pneumothorax can occur. Again, nodules that enlarge and cavitate, making bizarre cysts. The third one in this rare group, there are three: alveolar proteinosis is a rare disease characterized by filling of the alveolar space by PAS positive material due to abnormality in the surfactant metabolism. The diagnosis is based on high resolution, which show high resolution CT, which show crazy paving pattern. Usually between 30 and 50 years old, the patient presents with non-productive cough, fever, and mild dyspnea. Prognosis is improved by bronchoalveolar lavage. The most characteristic pattern is crazy paving pattern, in which ground glass is associated with interlobular septal thickening. But we can also see ground glass opacities and consolidation. But take care, as I've told you, crazy paving is not specific only to alveolar proteinosis. We can see it in a lot of diseases, including bronchoalveolar carcinoma, severe pneumonia, and unfortunately, nowadays we can see it in coronavirus-induced. These are the alveolar proteinosis: crazy paving, septal thickening, and ground glass opacities. It ranges from diffuse, like this, or multifocal, like this, with areas of air trapping around. Clinical here is very important causes of alveolar proteinosis. You remember what are the simulator general or great mimickers in these presentations? First one is sarcoidosis. Second one is cryptogenic organizing pneumonia. The third one, bronchoalveolar carcinoma, and now its name has changed to adenocarcinoma, low grade or carcinoma in situ. It can present by any pattern you have seen in. Look for this: nodules, solitary nodule, patch of consolidation, multiple nodules with septal thickening, patch of consolidation, crazy paving pattern, okay, patch of consolidation with areas of air lucency. Usually when I report cases like this in elderly, especially if I report that it is a pneumonic consolidation, I usually describe that the patient has pneumonia, but considering the age of the patient, post-therapeutic close follow-up is mandatory to rule out the possibility of being carcinoma, or to proceed to bronchoalveolar lavage or something like this, because I've seen many patients presenting like this as if it is a pneumonia, and actually it was not a pneumonia and it was a bronchoalveolar carcinoma. So it is a great mimicker that you should put in mind. I know that these diseases are difficult, but I believe that if you repeat reading these slides several times, you will find it a more or less more easier. Let me try to summarize. If we see a patient with hilar and mediastinal lymphadenopathy with small nodules along the peribronchovascular bundles, fissures, and septi, and the patient presents with fever, weight loss, fatigue, and erythema nodosum, what do you think about what he has? Sarcoidosis. If the patient has centrilobular nodules of ground glass opacities or mosaic pattern, and he's known to be a farmer or has certain drug treatments, or he is a bird breeder, what do you think? Hypersensitivity pneumonitis, subacute hypersensitivity pneumonitis. If he has centrilobular nodule of ground glass opacities in the upper lobe and he is known as a heavy smoker, what do you think? Respiratory broncholitis, interstitial lung disease. Clinical is very. Has bilateral peripheral consolidations in response to various drugs. What do you think? Cryptogenic organizing pneumonia. The same pattern. Bilateral peripheral consolidation with upper lobe predominance, and he has eosinophilia in his blood count. chronic eosinophilic pneumonia. They are the same, but this one lacks eosinophilia and this one. Numerous cysts all over the lung in a premenopausal woman or in a patient with tuberous sclerosis. LAM. Nodules of bizarre shaped cysts in the upper and middle lung zones sparing the lower lobe in a smoker. Histocytosis X. Focal smooth thickening of the interlobular septa in a patient with a known malignancy. Focal smooth thickening or beaded thickening of the interlobular septa with or without lymphadenopathy in a patient with a known malignancy in the chest or outside the chest. Lymphangitis carcinomatosis. Smooth septal thickening, ground glass opacities in a gravity-dependent location in a patient with cardiomegaly and pleural effusion. Cardiogenic pulmonary edema. If you find basal and peripheral reticular opacities with honeycombing and traction bronchiectasis, UIP pattern of interstitial pneumonias. Basal ground glass opacities, traction bronchiectasis in advanced disease, NSIP, diffuse consolidation and the ground glass that progress to fibrosis, AIP, ground glass opacities often in combination with cystic lesions. You can think of LIP or pneumocystis carinii pneumonia, depending that the patient is Sjogren syndrome or AIDS patient.